in interventional cardiology and over the last years, particularly in structural heart interventions. You're an amazing friend and a mentor, and we can't thank you enough for joining us. The stage is yours.
Well, thank you very much. It's really, I mean, I have followed the Journal Club for quite some time. The last time with a meeting from Switzerland, and when you told me that there's some opening, I'm very happy to fill in, because now I have a little bit more time, obviously, to think, less travel, and I wanted to share with you some of the things that I believe will change maybe in structural heart disease. So I open up my thing here. Did you share the screen, Azim?
No, we can't see your slides yet.
Wait.
You need to do it shared from your side. If you look at the bottom, there's a green button.
Let me just do. Okay.
Yeah.
Okay.
Millie, can you do it remotely?
Yeah.
No, I can't.
No. Wait. Share.
There we go.
Yes, there you go. Perfect.
Yeah, I'm not used to this stuff. But so my Corona Diaries, reflections of the past, present, and future of structural heart disease. And obviously, let me just see. Obviously, we start with the financial disclosures, which are listed here. So COVID-19 has dramatically changed medicine in our everyday lives. This is an excellent opportunity for the medical community to demonstrate the robustness of structural heart disease or heart therapies and provide optimal treatment despite the challenges facing hospitals, clinicians, and patients. In this presentation to come, we will focus on structural heart disease and COVID-19, the state of structural heart disease before COVID-19, impact and response to COVID-19, and then reflections and lessons learned in the last part. So first, I would like to start with the state of structural heart disease before COVID-19 and talk about heart failure therapies. Obviously, Azim and I agreed, and Ulrich, to cut this a little bit down because there are different meetings for this topic. Heart failure you have been talking about, and mitral and aortic valve diseases are following. So I just touched base on it, but I think it is important that we still talk about some unmet need in heart failure with reduced ejection fraction. Therapy for this type of entity has made remarkable advancements in the last few decades. However, there remains a large unmet need for additional therapies that more effectively induce remission, safely improve myocardial contractile performance, and induce reverse modeling. A number of new therapies are under development to target the pharmacological pathways, surgical and percutaneous therapies, and the biologicals. If we look at the interventional therapies in this entity, we know CRT is the key therapeutic strategy, but a significant number of patients do not respond or cannot receive a coronary sinus lead. CCM, cardiac contractility modulation, acutely augments myocardial contractile performance and chronically induces reverse remodeling. The therapy was recently approved by the FDA, but obviously more studies are needed. LVADs are an important therapy for those with advanced heart failure, as we all know. An atrial septostomy, creation of an atrial septostomy to lower left-sided filling pressure is a potential therapeutic option. And also renal denervation has recently demonstrated efficacy for blood pressure lowering. If we look at the biological therapies, we look at gene therapy and stem cell therapy. Gene therapy utilizes adenovirus to target the excitation contractile coupling apparatus that has established safety in the early human studies. Stem cell therapy for heart failure has been under investigation for more than 20 years, or almost 20 years, with trials demonstrating safety, but mixed clinical efficacy outcomes. If we look at heart failure with preserved ejection fraction, in contrast to the previous entity, there's a broad range of proven effective therapies, understanding of heart failure with preserved ejection fraction pathophysiology, however, is still incomplete. Guideline recommendations are vague and focus on diuretics to relieve symptoms due to volume overload. Control of hypertension is also suggested as an important treatment strategy. Studies have estimated that approximately 50% of adverse outcomes and clinical events in heart failure with preserved ejection fraction patients are driven by their comorbidities, including obesity, HDN, coronary heart disease, diabetes, COPD, anemia, CKD, and SDB. So if we look at the state of structural heart disease before COVID-19, interventional valve therapies, and again, I don't want to get into too many details, just touch on a couple of points. In recent years, treatment options for valvular disease have grown tremendously and have been truly disruptive. This pace is likely to continue with future interventional therapies targeting aortic, mitral, and tricuspid valve diseases. If we look at the repair devices, they're summarized here. Basically, a number of devices were targeting the leaflets, the chordal apparatus, and the mitral annulus, and they are under development. Overall, TMV repair devices show good safety outcomes, but improvements in ease of use and efficacy are still required. If we look at transcatheter replacement devices, and we're talking about them in humans, these show excellent MR reduction, but poor safety outcomes and compared to transcatheter repair devices. And this is a total about 700 basically, and those are the ones transapical and transfemoral devices are shown here with the number of reported human experience. The good thing about TMVR is that once the devices, here as an example, the Medtronic Intrepid, Tiara, and the Abbott Tendyne, once these devices are implanted successfully, they virtually eliminate mitral insufficiency. That's what the goal of this treatment is. Tricuspid is a little bit more difficult, obviously. The current state of transcatheter therapies, I don't want to go into details, but a report of 312 high-risk patients included in the International TriValve Registry showed 92% of patients undergoing transcatheter therapies had functional secondary TR. Patients were mainly treated with therapies designed for the mitral space and saw a 70% procedural success rate with excellent safety outcomes. As you can see here, the vast majority have been treated with mitral clip and with a cardioband. Novel transcatheter devices are in the early stages of development and may provide additional options for patients in the future. So far, so good. So now we change gear a little bit to impact and response to COVID-19. The COVID-19 is global inside the body. Not only this virus impacts the respiratory system, but eventually it is affecting also the cardiovascular and other body systems to a level we do not know for sure as of yet. We as cardiovascular physicians have to pay attention to such secondary issues. This nasty, highly contagious virus has challenged the healthcare and total hospital systems. Sudden influx of patients, many of them require intensive care, large number of diagnostic tests with limited lab capabilities, staff and patient intensive safety, triage of patients, delay of most elective procedures, lack of equipment and protective items in ICU beds. All this require optimal management of resources, improvisations, and shifting of staff to the coronary departments, which requires also on the fly additional training. The most critical aspect of hospitals to manage during pandemic is resources allocation. Number one resource, obviously, physicians and supporting staff. Other critical resources are protective items, respirators, and ICU beds. No one planned for the scope of the pandemic. Resource utilization became very critical. The number of infected varies drastically by geography. age, and gender. Despite globalization, different regions require different management. For each phase of the infection, surge, plateau, and resolution, different strategies and resources are required. Under pressure, we cannot ignore the need to handle routine, high-risk patients, including those cardiovascular and structural heart disease patients. If we look at the level, the resource utilization and the level of resource restrictions, we can see here the Canadian Association of Interventional Cardiologists suggests dividing hospitals into 3 categories determined by the level of impact of COVID-19. Hospitals with minimal impact of COVID-19, level 1, here in green, can have minor restriction in resource utilization, while hospitals in regions where the impact of COVID-19 is extreme, level 3, will have vast restriction on resource utilization. Structural heart patients during the pandemic, we would suggest the minimalist approach, obviously. TAVI should be done with this approach that is conscious sedation, transfemoral access, and early discharge. In highly infected regions such as New York City, same day or next day discharge is required for TAVR patients with possible digital and or video follow-up. The triage of structural heart patients during the pandemic is always very, very difficult and being discussed. With influx of patients, structural heart physicians face the challenge of determining which patients need to be treated versus which can be delayed. It is risk management under heavy constraints, risk of mortality, and risk of being infected in the hospital. We have to choose and look for ideal candidates, resource availability and safety on one side, and risk of mortality and event on the other side. An example of guidelines in this triage is the New York Presbyterian Hospital, Columbia University Irving Medical Center that issued guidelines emphasizing the balance between qualified candidates, resource availability, symptoms, and expected survival. These guidelines also provide specific metrics for aortic stenosis and mitral regurgitation to determine patients at risk. As you can see here, tier 1, emergent and urgent, tier 2, semi-urgent, and tier 3, elective. If we look at the ACC and SCI guidelines, they provide additional recommendations dividing TAVI into 3 categories. The first one should consider TAVI patients that are symptomatic, reduced ejection fraction, and 3/4 congestive heart failure and or syncope. Reasonable to consider TAVI, minimally symptomatic, high peak or mean gradient, very small valve area or very low DVI. Reasonable to postpone patient with asymptomatic severe critical aortic stenosis. Above all, obviously, staff and patient safety is important. Keeping the staff safe is essential. Determining the optimal approach for this is dependent upon protection and testing availability and impact of COVID-19 in a specific region. Methods to keep staff safe include use maximum available protection, test patients and staff for COVID-19 prior to hospital visits and shifts, use telemedicine instead of inpatient visits, keep staff to minimum in structural heart procedures, allocate separate hospital space to COVID-19 positive or probable patients and COVID-19 negative patients, virtual meetings between staff, limited patient pre-workup. And now, reflections and lessons learned, my diaries. Part 1, February to March 2020. One day in February, I woke up in Germany to these news. With 4 million miles on Lufthansa, I simply could not believe it. A virus would stop me from going anywhere. Like most of my colleagues, I was caught by surprise at the fast speed of this virus. And I was amazed by the lack of information about it and the lack of global readiness. I noticed people are running to buy toilet paper as if it was a vaccine. I saw politicians offering snake oils, disinfecting agents, and useless anti-malaria pills as the useful therapy. Hospitals were going camping, building tents in their backyards. Seeing my colleagues' physicians dressed like aliens, just landed from outer space. Seeing my own family members dressed like space warriors, fighting an invisible enemy. On the right side, my son Matthias, on the left side, my daughter-in-law at the unit in Georgia. I saw the number of infected growing exponentially, and unfortunately, many bodies in bags. Then I fully realized that we have a serious pandemic on hand, for which we were not ready. While at home, I watched, like many others, the TV news that only added to the public panic. Being in the high-risk group, I just passed the age of 40, I had lots of time in between hospital work to think about what really went wrong and what we learned for a safer, what can we learn for a safer future. So let us briefly talk about globalization, because everybody talks about it in this context. My first lesson, and this is part 2, the importance of globalization. To better understand the role of globalization in medicine, I need to take you through some basic concepts, I believe. How medicine progresses, the main drivers: scientific and clinical research, innovation, entrepreneurship and technology, clinical evidence, business opportunities. If we look at scientific and clinical research and look at the ancient world, medicine was developed and progressed in different directions, independent of each other. Chinese traditional medicine started 5,000 years ago. Egyptian medicine started 3,000 years ago. And European medicine progressed with Leonardo da Vinci in the Middle Ages. If we look at innovation, entrepreneurship, and technology and its impact on medicine, we can see 2 types of innovation and technologies that have been instrumental in developing medicine. Number 1, innovations in science. That gave us the tool to understand the source of diseases and to treat them. Number 2, innovations in technology and communication. That allows us to read and store printed matter, big data, and images. It provides tools to analyze those big data, and as important, allows us to communicate across continents, to travel, and to share knowledge and experience. Marco Polo's 5-year journey from Venice to Beijing today takes 9 hours, including a nice dinner and a movie. Business opportunities as a driver. With rising costs to attain commercially viable therapies, financing and business becomes an important partner in the development process. Today, from idea to commercialization, developing a new drug may cost up to $500 million. Developing a complex implantable device may cost up to $200 million. If we look at clinical evidence in medicine then and now, historically, medical experimentation was very limited. Knowledge and experience remained within city perimeters or within the palaces of rulers and faced heavy resistance from the church and other institutions. In the Middle Ages, during the Renaissance, once books became more available, medical books began to appear as a source of information, but with limited clinical data and limited peer review. And now, today, with high-power computers the size of a mobile phone, data is collected and analyzed globally and allows us to conduct statistically significant, globally implemented clinical studies controlled by professional regulators. Globalization is not a new concept. From prehistoric times throughout the Egyptian, Greek, and Roman empires, know-how was transferred from country to country. When the Roman legions occupied the old Middle East, they brought winemaking know-how to those countries, so their soldiers could be paid in wine. That was an early example of early globalization. Accelerating the need for globalization, fast growth of technologies, more complex technologies requiring specialization, global access to information via the net, availability of efficient communication across countries, increasing global standard of living, accumulation of wealth, and dependence of countries on what happens in other countries, politically, medically, and economically. The technology development acceleration is simply mind-boggling, as you can see here, with a start in the 50s, 60s, with the computers, with the chips, cell phones, and computers. And so is medicine. The fast growth of information. The number of books you need to read to become an MD, one book in 1670, over 98 books in 2020. This is where globalization meets medicine. Not only have we substantially increased our knowledge base and solved many unknown diseases today, but the remaining challenges and unmet needs still to be solved are highly complex and difficult. Solving them requires expensive resources, human and financial, as well as time. Solving them requires, obviously, a multidisciplinary approach. Interesting case study, PVT, where globalization accelerated a solution in structural heart disease. The subject, replacing transcutaneous aortic valve. The idea born in the United States. The technology was developed in Israel. The key component, tissue, manufactured in Australia. The animal studies in France. Clinical studies globally, in total over 10,000 patients in 9 multiple studies. The production today in the United States and Singapore. And the current size of business over 5 billion. What does globalization and homogenization mean for medicine? Sharing clinical information across the widest possible base, creating dialogue and peer-reviewed criticism. Providing early notices on critical and difficult events, cases, and solutions. If homogenization can ever be achieved in regulations, it will make clinical studies less expensive and expedite availability of new therapies to patients in need. Learning from each other will allow us to combine different, reinforcing therapeutic approaches for better outcomes. Then globalization might change the way we deliver healthcare, making hospitals more efficient by adopting support technologies like IT, allow for specialization, widening the focus and attention of clinical research and industry to emerging countries with affordable solutions, expand medical education options, and creating patient demand for improvements based on information on other countries. Globalization and doctor-patient interaction. Patients are becoming more knowledgeable and educated globally. Globalization allows cross-country and continent consultation. Informed patients will demand more from their physicians. Physicians will learn to work with patients remotely. robotic technology will partially replace physicians, and patients will be in a position to select their physicians based on their quality criteria. What stands in the way of globalization? Politics, politics, politics. They say globalization is an agenda of the rich states and their multinational corporations, the source of economic crisis with loss of blue-collar jobs, increased protectionism and neocolonialism, conservative politics of isolationists against democratic rights of the ordinary citizens. However, globalizing medicine proved to be a must. In medicine, globalization becomes a must if we want to achieve the goal of eradicating diseases. People well-being outweighs any politics. Healthcare costs are rising globally. Globalization can help reduce them. My last part, other important lessons during the COVID time. COVID-19 pandemic, lesson number 2. Viruses do not recognize and respect international borders or trade wars. Awareness and early notice is critical to win such pandemics. Data becomes the key tool in such a battle. Sharing resources globally saves lives. We need an early warning global system. All this is also provided by globalizing medicine. The next lesson. The way we will deliver healthcare in the future will change dramatically. More patients will be treated at home. Physicians should be trained also in intensive care procedures. Hospitals should have plans for crisis. States and countries should have an emergency storage with therapeutic needs for natural or man-made disasters. Number 4, digital becomes a key healthcare tool in fighting pandemics. Data analysis is critical to let us know what is going on. Patients monitored from home will ease hospital congestions. Informing physicians in real time on developments. Have the public being informed with real facts. Sharing medical resources. Number 5, trust but verify. The politician's role. Trust politicians only based on facts and actual data. Know how to avoid fake news. Internet access must be a civil right. We will have to trade some freedom for public safety. Healthcare is an integral part of national defense. Aircraft carriers with sailors infected on board become useless. Lesson 6, different lifestyle. What is new and important? Working from home, washing hands, soap really destroys viruses, learning to cook, family and friends, social distancing is annoying but essential, shop the internet, the end maybe of big malls, and appreciating nature more. Number 7, innovations in medicine. We need to keep supporting it. Scientific and clinical research, innovation, entrepreneurship, and new technologies. Even in days of crisis, we should keep data and information based on clinical evidence, not on shortcuts or improvisations. Lesson number 8, and finally, the soldiers that are standing on the front line, protecting us during a pandemic, are the physicians and the medical teams. They deserve our respect, gratitude, and support day in and day out. So in conclusion, viruses, bacteria, and other diseases do not recognize and respect political borders and trade barriers. It is beyond just business. It is our professional and human obligation as physicians and healthcare entrepreneurs to bring to any and each human being the best possible therapy. Global collaboration is the prerequisite to succeed in reaching the utopic goal of healthcare to provide solutions to most diseases. We are all one world, one mission of making life better, safer, and healthier to all. Thank you very much and be safe.
Thank you, Eberhard. It was very well done, very inspirational. I do think, though, you know, I hope that Lufthansa starts flying again, so you can get on some planes soon, because I can see you've had a lot of time to think and think about how this is all affecting us. I did want to ask you one question. You know, well, I have a number of questions actually I want to ask, but the one I wanted to start with was, you've been very involved in sort of innovation and bringing, you know, new devices to practice and to clinical practice, and that have helped and addressed you know, really unmet clinical needs. I mean, how do you think this corona, the COVID crisis is going to impact that? I mean, a lot of these companies are startup companies, and they, you know, they've now possibly lost months of their planned timelines. They may lose funding. What impact do you think this is going to have?
Well, Azim, as you well know and see yourself now, you touch base on a very, very important thing, and that is this whole pandemic slows down basically everything. I mean, the FDA is still working, so if you look for studies, but then, you know, the problem is how to do the financing. Right now, the financing, basically everything is a problem to support these startup companies. Here in Europe, we have the governments stepping in to support the startup companies, because the investors are very, very careful to support them, because they don't know what the future is holding. So these startup companies get help from the government here in Europe. I'm sure this is something that's being discussed in the United States. As you well know, in the United States, you have many people laid off. Everything is, if not on hold, but is delayed. So we're going to have, I think, in terms of studies, I think the studies are resuming slowly in the United States and here in Europe. I heard from Nicolas that, you know, people are, you know, are still enrolling, hospitals are still enrolling patients in the studies. So we're coming back to normal, but for the startup company, it's going to be very, very difficult to survive this. And I can only hope that either the investors or the governments will be able to support them, and there will not be a sellout of interesting technologies for a low price, and then big companies will secure the IP or even the devices. We'll see how that goes, but it's a very, very difficult time for them. And you all know this, you know, everything is slowed down.
Yeah, I want to give you guys are interventionalists, I'm not. So I always try to bring a little bit different perspective here. I think it's very important for us right now to convince our colleagues and the public how important advanced healthcare is. Because it's, for me, as transplant elder cardiologist, you really do some soul searching when you see this and you say, what am I doing? I have a whole center and I focus on, you know, 50 to 100 patients a year with this heart replacement therapy. And meanwhile, we just got 5,000 admissions and had 1,000 deaths. So you start to question the utility of this. And I think this extends to structural intervention, where you say, what are we doing? Is this just for advanced Western rich countries to do something? And I think the answer is no. What we see right now is I'm convinced that in New York already, we're in an advanced phase of this, that more people are dying or getting long-term health consequences from not having their heart disease taken care of because of COVID than people who are actually still dying from COVID. You see in the interventional literature all these dramatic case presentation, ventricular septal defect, people forgot about it, now it's happening all the time. So I think this has to be part of our messaging, that we say, this is a terrible tragedy, but let's look at what we have achieved in the past 30 or 40 years, and particularly past decade with structural heart failure. That's an important message that we have to again get out there, and I hope Azim and I have talked about this, that this forum hopefully can contribute to that.
And this is very interesting, Ulrich, because what we saw, and Azim, I've talked to many of your Italian friends and colleagues, the number of acute infarcts, I don't know, you've probably seen this too, the number of infarcts, were dramatically down. And we were asking ourselves, where are these patients? Are they just, with ACS, maybe you can say, okay, I take a pill or something like that, but an infarct is an infarct. Where are they? And I think gaining, patients, they're coming back now, as you said, with much more severe symptoms, more severe complications. We do see VSDs now much more frequently, which we haven't seen before that much. We know of this complication, but now it's happening more often, which is probably to say that patients were afraid to go to the hospital. They stayed home because they were afraid to get infected. And I think getting the confidence back to patients is a very, very important message, as you said. But that again goes back to leadership. If you trust in your leaders, and they present, the situation in a balanced, intelligent, empathic way, it's always in a threat from outside or inside. People gather around the leaders, but these leaders have to be responsive, and they have to carry this message and the responsibility in a very high level way. And that's why when I said about don't follow fake news, we had a massive daily information about numbers, and they were contradicting each other here in Germany. I'm talking not about the United States. So people were eventually, they shut down the information because they didn't believe it anymore. This is a very good example. We believed basically in the leadership. The parties were unified behind the leaders, and then the virologists and the institutes that gave numbers, basically nobody listened anymore. And I think this is an important message. If you lose confidence in your leadership in times of threat, that's the worst situation that you can get in.
Yeah. And
we see this, I think, every day. And unfortunately, not to speak about the United States, we can see it in Europe, and very, very dramatically now in South America.
Yeah, very true.
Yeah.
I think like you mentioned in your talk, Eberhard, their opportunities. I was thinking what Uli said about creating confidence. Today was the first time in about 2 months we restarted our structural heart clinic, and we have a whole lot of patients we've been talking to over these last 2 months with very severe aortic stenosis, very high gradients, who need to be treated. And now we call them today, and we try to get them to come in. And these are patients who we know the natural history is poor. I'm talking about gradients, mean gradients of 80, 90. Majority of the patients we call today refuse to come into hospital, refuse to come in for a outpatient visit, so we could get them ready for their TAVR procedure. Yeah. And it's forced me to think that because of this crisis, sure, we need to create confidence that the hospital's safe, but we also maybe need to change the way we're forced to change the way we do things. So one of the things we've thought about now is, should we move to doing even the pre-procedural visit with the consent and the explanation all by video. Okay. How do we limit the number of times the patients come to hospital? So instead of, normally they would come for their CAT scan, then they would come another time for a coronary angiogram, then eventually for the procedure. Can we now condense that into as little time as possible so that patients don't have to come to the hospital very often? And then, like you mentioned, what can we do to streamline the procedure to get majority of patients home at least by the next morning after their TAVI procedure? I think it's forcing us to do things that I think in the end will be good for patients and for patient care, but now we're being forced to do it in a more systematic way and under pressure.
Azim, when I look at the situation, and I can speak about three major cities here, Cologne, Bonn, and Düsseldorf. Basically, we never gave up the TAVR program because first of all, we provided beds. So we had a huge amount of beds available for possible COVID patients. Once that has been established, we continued the TAVR program because we believed TAVR in itself, if you're very sick, has a mortality, which actually might be higher than a COVID patient. And so we continued, but as you said, in a condensed way. We asked the physicians before the patient got into the hospital to do all the workup, which you usually do as part of the workup in the hospital. Everything was streamlined, condensed to 1 day pre, and then as opposed to what we are supposed to be doing, as you know, in Germany, we only get reimbursed if we keep the patients for 7 days in the hospital. We did next day or 2 days after procedure discharge, which obviously is a strain on the financial situation, but we couldn't afford it to do it any differently. So we streamlined, as you said, tried to streamline as much as we could. On aortic disease, structural disease on the mitral valve, tricuspid valve, unless a real emergency, we postponed to elective. And we continued the TAVR, severe symptomatic aortic stenosis. That is being resumed now. Now we are ramping the cases up. And the same thing is happening in surgery. The patients are coming back now. We were a little bit afraid, is what you said, Ulrich, that patient, they're losing confidence. I don't want to come to the hospital. If I can wait a little bit, why not waiting a little bit? Now we're building this, we're calling them and we're telling them they're safe. We're building these rooms, special rooms where we inform them that they are safe. And so they're regaining their confidence. But this is an educational process. We have never seen this before. We have never dealt with something like that before. So we didn't have any idea way of doing things. We can only learn things and hope that the next time something like this is happening, that we're better prepared. And granted, the United States New York City got really hit badly. Yeah. If I talk to my friends in Sacramento, they haven't had any case. So, it's geographically quite different. The reason why that is happening in New York is probably obvious, but that didn't help the ones that are very sick or even died, even the physicians.
Yeah, let's talk a minute. You're absolutely right. We are very hard hit, and we have the logistics are very important here. And Azim alluded to it. We have now on our chat here, we have a question from Aisha Kader. First of all, thank you to you, Eberhard, for a terrific, brilliant, holistic talk, to be precise. There's a question I'm going to ask both you and Azim to answer that briefly. If you were to do an elective, or let's say an urgent procedure on a patient from the outside, are they all given a test? If so, which one, virus or antibody, prior to taking them to the cath lab? And if you do that, how long before the procedure would they have the test? Maybe Azim, I know you just developed the protocol for us. Maybe you just explain briefly how we do it.
Yeah, sure. Thanks for the question, Aisha. What we've been doing here at Monty is for any patient coming from home, so from outside the hospital, we've been asking for them to have a negative swab within 48 hours of the procedure. To be able to do that, you need to have a dedicated testing area where patients can go to and be tested safely. We've had to do some urgent procedures. So, electives becoming very quickly urgent. So where they couldn't get the test within 48 hours of the procedure. And those patients, we have a rule that, they come into a specific area in the cath lab where we have rooms that are closed with negative pressure, and they get a swab. And until the swab result comes back, they don't enter the other area, or the cath lab. And I have to tell you, we've been doing this for the last couple of weeks, and in the last week we've had 3 patients who, on the telephonic screening the day before, when you ask them all the questions, have you been in contact with anybody with COVID? Do you have any symptoms? Are you concerned you may have COVID? They've all said no, 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 and they've all been completely asymptomatic, but with positive tests. Three of them. So I think you have to realize that if you're going to restart elective procedures, testing has to be an important part of it. I think Uli said, what testing? I mean, we're doing swabs. I think if you really wanted to be as scientific as possible, you should probably swab as well as do the antibody test. It will help you pick up some false negatives of the swab, but also it will help you build a sense of your community that you serve, of how much infection there is and how much herd immunity there is in the community you serve.
So, Ulrich, you probably know the situation in Germany. Some of the major advantages that we had, we were prepared and we took this pandemic very seriously. The University of Bonn has a testing center, but we have 2 remote testing centers where patients are being tested. So, for example, in Bonn, we have 2 in the city of Bonn and 1 in Bad Godesberg, which is a suburb of Bonn, and then the center in Bonn. So the testing capabilities, availabilities are very, very high from the very beginning. That was probably one of our advantages here. And now if we do an urgent procedure, we try to do the same thing that you do in New York. We try to do the testing, the antibody and the swab, but if it is an urgent case, we don't get the results on time, then we kind of do it differently. Then we have a special cath lab that we do those patients that we cannot test and do that remotely. But normally when patients are coming in, they are tested and they should be tested, because then the whole mess is starting again.
Yeah, Azim, maybe I wasn't listening properly, but maybe also can you tell everybody about the compartmentalization of our cath lab into COVID positive, known COVID positive, and known COVID negative patients, that avoidance of people going to the same lab?
Yeah, no, we've had to come up with unique ways of repurposing our spaces in the cath lab. So one of the first things we created now is we have a COVID positive cath lab. So for patients who are COVID positive, who are suspected, where they can get into the cath lab and not be in any contact with any of the other cath labs or any of the patients that we're working at. We then have an area where patients will come into, where they'll either get their tested or be pre-opt, get their procedure in 2 COVID negative cath labs, and then go to a COVID negative area. And we've really, had to work on patient flow and have the staff understand. The other thing we've had to stress is really the importance of universal precautions and just using PPE all the time. I did want to say to, the participants who joined us, Uli, this is the kind of conversations we've been having, are difficult conversations, maybe sometimes to ask a question with a chat function. So today we've allowed you all to unmute yourselves if you need to, and you'd like to ask a question to Eberhard or me or Uli. Please feel free to. We have about 8 minutes left before we'll close the session.
So waiting for the questions, I think that was the lucky situation that we were in. We have not seen, like 2 weeks ago, we have not seen any COVID positive patient in the cath lab. I mean, imagine that. We were just waiting for them to come and they didn't come. So
Yeah,
we
hopefully they won't come. I mean, to your point, the situation in Germany, you know, my brother is a physician in Mönchengladbach. He's in a basically general practitioner, serves a community of, I don't know, 50,000 or so. He's been doing antibody testing in his office for the past 4 weeks. And he's a small, just regular Joe practice. I hope he doesn't listen right now, so to speak. Yeah, I think next week I think we'll give some detail on further detail on how we're ramping up again structural heart failure, also how the heart failure visits are changing. And like you had said earlier, about there is definitely an opportunity here to reach out to people, you know, and many patients might actually be much more comfortable being at home for their visit. If the physical exam is not essential, you can be relaxed in the privacy of your home without white coat hypertension. I'm probably late to the party of telemedicine, I have to admit it, but this experience has taught us that we can do a lot, as we're doing now, just remotely. But I think there are some questions on the chat now that go back to the actual topic. Yeah, yeah, you take this one, Azim. from Drew.
Yeah, well, I think, you know,
Andrew.
well, I'll maybe pose to you two the Dr. Grumman's question about, which I think is something we've all thought about. You know, would it make sense to split, especially a big hospital system like ours, to split the hospitals into COVID positive, COVID negative hospitals? So cohort all the patients into one area, and so have a truly COVID negative hospital. Uli, thoughts? I have my own thoughts, which I'll share in a moment.
You're gonna get me in trouble?
Yep.
Well, I think it would make, intuitively, it would make a lot of sense. But then when you think about, I guess you would have to redirect the STEMIs. The unknown cases would have to be redirected, which for us maybe, you know, I guess might lead in a worst case scenario to 20 more minutes travel time in the Bronx from one lab to the other. So I think if it was logistically feasible, it should be done. At this moment, with the current saturation of cases and the limited ability of testing still, that's the big issue. Yeah. I quite frankly, I don't think it is feasible to do it, because you just can't screen quick enough, know is positive is not, to then, someone has STEMI, where you're going to bring them. You don't know, unless you'd say, I'll bring all STEMIs to one lab, because that's quote unquote the dirty lab. What do you think?
Yeah, no, I agree. I think the biggest limitation is testing, really. Yeah. I did want to ask Eberhard another question related to the epidemic and its impact. Eberhard, you know, you've been the PI of many clinical trials over the years. One of the things that, you know, we've been struggling with and thinking about as well is how we restart clinical research and our clinical trials here at Montefiore. I mean, you know, how do you restart enrolling patients in clinical trials? Also, what impact has the epidemic had on, you know, mortality rates, event rates? Can you cloud the data now if you restart clinical research and you have patients who now get COVID afterwards and don't get to the primary endpoint? You know, do you mess up all the data? So I've noticed that, you know, a number of the large clinical studies, industry-sponsored clinical studies we've been involved to have stopped enrollment, and they've been very quiet about when they're going to start enrollment. Have you had any thoughts about this?
Yes, of course. And I think it is a very, very, very important question that you're raising. Actually, probably not many people have thought about this. Obviously, the tertiary hospitals and the hospitals that are doing these studies are directly affected by it, because there might be actually a bias, there might be confounding factors now with COVID positive, negative, how to separate them. Are they included in a study? I think for the time being, I think you have to really stop and reconsider what are we doing, because we cannot include, depending of course of the study and the endpoints of the study, we cannot mix a COVID positive patient with a COVID negative patient. That might be a confounding factor, and then all the data will probably be useless. So this is something that has to be reconsidered. I'm totally in agreement with you. I don't think anyone has really seriously figured this out, because right now we have been fighting this pandemic in the acute and subacute phase, if I may say, or the first wave. For example, I've talked to physicians in Singapore that wanted to restart, and they stopped everything because the data were completely messed up. They tested everyone then. The testing abilities weren't that high because they were reducing it, and this has to be reconsidered. I think from scratch on. I think right now the best thing is to stop, put things on hold, and reconsider everything, how this is being done, looking at the endpoints and looking at whether, how, and how much a COVID patient could actually confound the data.
Yeah, absolutely.
I have also a good example for this. You may be familiar about probably the Momentum trial is, the largest LVAD trial in the world with thousands of patients, was mostly completed, but there's still follow-up. And for us, the next study in this patient population is going to be to, and I spare you the detail on the background, but to randomize patients to be just on Coumadin plus aspirin or no aspirin at all. That's one of the big questions that is out there. And we talked about this last week with the steering committee, and we said, wow, with all the hypercoagulability issues with COVID, do we still have equipoise? And literally same day, this is an Abbott trial, same evening, there was an email from Abbott to all the investigators that are still following patients that the case report form had been updated in a mandatory way to basically enter COVID data. So we will get a lot of information, and this might be a good idea also when you guys worry about, I don't know, aortic valve thrombosis or something, to add this into some of the studies now to see whether there is an association, which there probably is, between, let the record say I had the idea on this chat, between aortic valve thrombosis and COVID.
But that's why I said, it's the time to stop and reconsider what's the best way to move forward in order not to go into the wrong direction and confuse things.
Great.
I think, Uli, that's a great place to stop. We've reached the hour. Maybe you want to just close up and tell us about next week? Yeah,
let's just make a pitch. So we're trying to get away from COVID, and we thought today would have been our exit point, but that's not going to happen. For those who have seen the news, there's a lot of information now that's very serious about children with COVID and cardiac involvement. We are again at the epicenter, and next week, actually Nadine Chortier, who is a pediatrician here, is an expert, has agreed to give us a review of what's going on here. I just went through this with her like an hour ago. It is as scary as fascinating, but in the end, for those of you with children, somewhat reassuring. So that's going to be next week. That's going to be the mechanistic part. And then in the second half, we do want to make the leap away from this, and we do want to do something that we've done very well here. We want to update everybody on the core cinch heart failure study, which is a structural device that cinches the heart catheter base from the inside, and it's going to be a very large 400-patient heart failure study, imminent to start in the United States. We want to give you some information. It's very exciting, but we also want to get everybody on the same page, how to get patients possibly ready for that study. Class 1 recommendations in heart failure, including Entresto and Aldactone, are going to be mandatory. And we will overlook the heart failure clinic. I'll talk a little bit about that. And that's going to be next week's topic. So pediatric COVID with a focus on cardiac and Kawasaki disease. And then how do we get ready for the relaunch, which clinical trial relaunch, I hope we get to that point late June, July. And that's what I believe. Good. So, Azim, final words?
No, just final words, just to
Bond,
thank everybody for joining, but especially to thank Eberhard for sharing your reflections in your Corona Diaries with us. It was very thoughtful and we really enjoyed it. Thank you, Eberhard.
Thank you, Azim. Thank you, Uli.
Great. Alrighty, be safe.
Yep.
Very good.
Take
Ciao.
care.